I'm good, Declan. Thank you. How are you?
Good. Always good to talk about bladder cancer. It is consistently one of the most popular topics on GUcast.
Absolutely. And you know what? We also love surgical randomised controlled trials. So we get both in this podcast today. Very exciting.
If you do a randomised control trial in urology and publish it in a decent journal, we would love to have you on the podcast.
Definitely. But this is a nifty little paper. I really like this.
It sure is. So here it is, hot off the press. It's just in press in European Urology. Do you want to tell us the title and where it's come from, Renu?
Yes, so it's transurethral en-bloc resection versus standard resection of bladder tumour, a randomised multi-centre phase 3 trial from the team led by Jeremy Teoh in Hong Kong.
Yeah, just fantastic. And we're so thrilled to have Jeremy joining us on the line from Hong Kong this fine evening. Jeremy, welcome and congratulations on this trial.
Congrats.
Thank you very much. Always a pleasure to be here.
Yes, he's no stranger to GUcast. He's a friend of the podcast for sure.
Yeah, and you've published this in European Urology, no less, so that's fabulous. Congrats to you and all your colleagues. We know very many of these authors on this list, of course, and senior author Anthony Ng, so congrats to all the group and you and your team for putting it together.
Thank you.
Yeah, it's a huge collaborative effort, Jeremy. And, you know, it's not easy to run these trials. So maybe we'll start off by how did you get the idea for this trial and how did you come up with the trial design?
Well, it's a long story. When I was a trainee, I was thinking, doing a transure resection of bladder tumor, we know it. So we put an endoscope and then we resect the tumor in a peaceful manner, fragment it, and then try to flush every fragment out. And then you finish when you think it's completely resected, right? But then we all know that the 1 year recurrence rate of non-muscle invasive bladder cancer is very high, 30-40% 1 year on average. Mm-hmm. And then we also know that in patients with T1 disease, for example, the chance of having residual disease is like 20-30%. And then it's always kind of shocking to me that as a surgeon, we accept second look surgery as a standard of care to compensate surgery. So this kind of question is really deep inside my heart as we all know, when we resect a tumor, there's always a chance of tumor seeding, and then there's a chance of residual disease. So I was thinking, whether we can do it by upholding the basic cancer principle and do it in an en-bloc manner. So that's how the idea came from.
And I remember my mentor at Guy's, one of my mentors at Guy's, Tim O'Brien, a big bladder cancer expert who's always been interested in surgical technique of TURBT, saying that when you speak to other surgical oncologists working in other cancer disciplines, the idea that there's your primary tumor, you're going to carve it into little pieces and scatter it all around the surgical field, but make sure it's contained within the surgical field, like reimplantation area, and then wash it out, never seemed to make sense. And therefore the idea of en-bloc, of course, has always been delicious. And I remember him fiddling around, messing around with the standard electrodes with a Collins knife and with loops, trying to figure out a way in which you could do an en-bloc and get under it. So there always seems to have been a slight, people have had the idea, but that there was a technical block that, look at our it's just not feasible. It's just not feasible to do it endoscopically in the bladder.
Yeah, and the quality of a TURBT is really important when it comes to diagnosis and staging. And like Jeremy said, with T1 disease, you don't know if you've left disease behind and you have to go in for a second resection. Have you sampled muscle? Is it a complete resection? These are all big considerations when you're treating non-muscle invasive bladder cancer. And I think this en-bloc resection technique addresses a lot of those.
And it's one of the reasons, of course, why bladder cancer is one of the most expensive cancers to manage. It's because of all the second looks and the re-resections and the subsequent intravesical
and the post-op mitomycins.
I suppose all these things we're talking about are laying out the argument for the requirement for a trial of a novel technique, at least evaluated in such a big trial, to see, can we address all that? So tell us
about the study.
And how you do an en-bloc TURBT.
So, the way that we do it, we basically use bipolar energy. And in our centers, we use the resection lobe, just the ordinary equipment that you use for TRP or TRBT. And then we usually would distend the bladder slightly and then try to mark the circumferential margin about 5 millimeter from the fist. After marking it, these are the landmarks for you to perform the circumferential incision. And what you would expect is actually mucosa and submucosa, they are very soft tissue. And once you have incised around the bladder tumor, these soft tissue will actually shrink into the middle. And then you can then try to use the resection lobe, not only for incision, but you can also use it to push against the tumor, almost like a blunt dissection. And you can identify the junction between the submucosa and also the diffuser muscle fiber. So you know exactly where you want to do it. And then we will try to, there's a bit of adjustment in the actual manipulation of your wrist. So what we do is usually try to rotate the resection lobe a little bit, so that the U shape is kind of below the edge of the tumor, and then just keep going from lateral to medial and vice versa, and you just keep going on until the whole tumor is being resected. And I think the good thing about this procedure is a very precise, controlled resection, because during the resection, basically you try to tap on the pedal in an intermittent manner, so that it's very precise. If you get too deep, and always adjust accordingly, and then you complete the surgery. So this is how we do the surgery. For the trial, we basically, we have a lot of good collaborators in Hong Kong. This is a multi-center trial involving 13 centers in Hong Kong. And then the main inclusion criteria will be bladder tumors of less than 3 centimeters. This is the main inclusion. And we don't have any restriction in terms of the number of tumors. Randomized trial comparing between en-bloc versus conventional TURBT. We recruited 350 patients, randomized in a 1-to-1 manner. And then after the procedure, then we would give one dose mitomycin C according to the EAU guidelines protocol. And then we would offer second look if there's an indication according to EAU guidelines. And then we do surveillance cystoscopy once every 3 months up to a year. And the primary outcome would be recurrence rate at 1 year. And then we also look into secondary outcomes, including progression rate at 1 year and also other perioperative outcomes.
So before you tell us about those results, so he described it very nicely, didn't he? You're going around the edge, 5 millimeters out, little taps on the diathermy, bzz, 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 and you're kind of going into the mucosa, go slightly deeper, and you can imagine yourself undermining it. Some positions in the bladder must be easier than others, for up to 3 centimeter sizes. Are some areas a bit difficult to get to? And I'm sure you'll tell us that in the results. Sometimes it just wasn't technically possible to complete en-bloc.
And I guess, when you're using that sort of staccato resection, you've got a little bit more control over the edges. But Jeremy, what is your target layer? Are you aiming to get to muscle and then continue that plane? Yeah.
So I always try to get just a tiny bit of muscle. So everything above the muscle, we need to take them out, but a tiny bit of muscle for mainly the staging purpose.
Right. And were there any that you couldn't complete that you intended to do an en-bloc resection?
So at least in our trial, we do it in a multi-center setting, and we're able to complete so-called a successful en-bloc resection in about 88% of the patients.
Okay.
So 12%, sometimes the tumor is just too big, you can't take it in one piece, or due to some other technical reasons, right? When the tumor, for example, is in the bladder dome, it might be more difficult to do a decent en-bloc resection. So 88%, I think it's not perfect, but it's a reasonable number. Yeah.
Very good.
And so it's with the loop, it's with a bipolar loop. I remember Tim at Guy's fiddling around with a variation of a Collins knife going forward, etc. But you can do this with a loop and you just bend it a little bit.
I think, there are many different ways of doing it. Bipolar, Collins knife, resection lobe, holmium laser, two-limb laser. To me, I think the primary thing is really the approach, right? What energy you liked the most, what you preferred. It's okay.
Yeah, very good.
And before you also go on to results, what about entrapment and all that? So you're allowing tumours up to 3 centimetres in size, but how do you get them out of the bladder? Are there tricks for that? Because I think that's always been one of the things that would put people off, saying, it's okay, I can do that disconnection, but now the thing is bobbing around in the bladder, or I'm going to have to kind of chop it up into pieces anyway.
In this trial, as the bladder tumor size has a restriction less than 3 centimeters, most of the cases would be feasible. For larger tumors, there are different ways, tips and tricks on making it happen. For example, some would use so-called endo-bags, put them in it, and then so that when you take it out, there will be less so-called seeding along the urethra. Some people would use a large, almost like the morcellator telescope. The reason of using is because the channel is quite big. It's 5 millimeter. And then you can use a small laparoscopic forceps to actually grab the tumor and then take it out through the sheath so that you don't have any seeding in your urethra. But the worst case, of course, there are tumors which you really cannot take it out. Then we have to take it out in multiple pieces. But having said that, I think en-bloc resection, although by its name is removal in one piece, but I want to emphasize that it's actually two components. First is about the resection quality, right? This is how you do it during the surgery. And the second part is so-called removal in one piece. So in my opinion, for large tumors, even if you have to remove in multiple pieces, but as soon as you ensure good quality resection, there might be still some failure doing it. Yeah.
Very cool.
Very cool. And results, what did you find? Tell us.
Is there a difference in recurrence rate?
Yeah. So basically what we found is that the 1-year recurrence rate in the standard resection group is 38.1%. And then the 1-year recurrence rate is 28.5% in the en-bloc resection group. So relative reduction is around 25-30%, which is quite good if it's just a modification. But to drill on it a little with the recurrence pattern. Yeah. Because the aim of the surgery is to ensure a complete resection and to reduce tumor seeding. And both ways of so-called recurring, they would lead to an early disease recurrence, right? Residual disease, early disease recurrence. Tumor seeding, early disease recurrence. And therefore, if you look into the curve carefully, the graphs actually tend to separate quite early on at 3 months' time. They're already separated. And they tend to have an incremental increase at 6 months and then at 9 months' time. And then if you look into the forest plot, which is the subgroup analysis, I must stress that our sample size is not really pre-planned for this kind of analysis. But interestingly, patients with 1 to 3 centimeter solitary tumor, TA tumor, and also intermediate risk tumor, intermediate risk non-muscle invasive bladder cancer, these are the patients who benefited most from en-bloc resection. And to me, it makes sense because these tumor solitary, if you can do it nicely without fermentation, then probably they will benefit most. Whereas in patients with multifocal, really high risk non-muscle invasive bladder cancer, these patients, the hazard ratio is more near the 1.0, which means that a good surgery alone is not sufficient. You need something more, maybe BCG or some kind of adjuvant treatment.
It's the nature of the
so it's really, understanding the primary outcome, the treatment pattern, the subgroup analysis, then everything seems to be quite compatible with what we'd expect. We also look into progression rate, but of course, the 1-year progression rate, the event number is not so big. So it's around 2.6%. In the conventional TURBT group versus 0% in the en-bloc resection group. And it did not reach a statistical significance. P-value is 0.065. And then all these other secondary outcomes, apart from the OT time, which is slightly longer in the en-bloc resection group, it's about 12 minutes longer, but other secondary outcomes are pretty much similar, including the safety outcomes, which are similar between the two groups. So basically, we concluded that by adopting en-bloc resection, we can improve the 1-year recurrence rate. We also believe that in a multi-center setting, it is generalizable and is safe to adopt, even you want to do it in other centers.
But even with the resection time, Jeremy, I was surprised that it's not a lot longer. When you hear about this en-bloc resection technique, you would think, well, that's going to be quite fiddly and it's going to take a bit of time. Yeah, and then you have to get it out. But in fact, 10 minutes longer is really, really nothing.
This is actually quite comparable with our previous retrospective data. And also we did a systematic review and meta-analysis of other studies. More or less 10 minutes longer in the en-bloc resection group is what we would expect. But I think, OT time is one thing. Most important is whether it's safe, complication profile is simpler. Yeah. And now with the potential benefit and the recurrence rate, I think we have a strong reason to really rethink about, how we should do the surgery.
I love it.
Yeah.
It's just fantastic. It's one of these things that you read this and then you think, why don't I am going to do this at my very next TURBT in a small tumor like this. And there's almost no excuse not to. Even without seeing you do the technique, even your description, anyone who's experienced it doing bladder cancer surgery understands exactly what you mean. 5 millimeters out, little bit of a mark it all out, and then. So why wouldn't all of you urologists out there listening or watching this? This is what you should be doing. This should be like an immediate thing that is now standard of care. Or am I missing something? I don't do bladder cancer anymore, but
I mean, it seems very straightforward. And you said that it was the patients who had the solitary 1 to 3 centimeter TA tumors that benefited the most from the improvement in recurrence rates. But I think there's a further subset of patients that have benefited from the more accurate staging, diagnosis, and initiation of early appropriate treatment.
Yeah, I think this is really the first trial which demonstrated the benefit in terms of recurrence rate, and therefore I think it's a really important trial. Really, trying to kind of forces people to rethink. This is something that we should do.
So, what are some of the drawbacks of this technique, then, Jeremy? Did you have any complications? What's the learning curve like? Is it teachable?
Yeah, so obviously in my opinion, the main obstacle is our mentality, our attitude, whether we're willing to relearn the surgery. When we do TURBT, it's many people would think it's an easy surgery and you finish in 5 minutes, 10 minutes. But we need to respect it like a cancer surgery. Just take your time to do it and do it properly.
Yeah.
And in this trial, surgery trials are really complex and difficult to run. Even for this trial, being able to convince a lot of collaborators to do it and gradually teach them how to do it, because as you would expect, they know how to do TURBT. They wouldn't have a lot of experience to do en-bloc resection to begin with. So I actually have to initiate a group of people who would like to learn it. And I think the technique itself is not so difficult. For me, about 20 cases, I feel fairly comfortable to do it nicely without the worry of increasing any complication. But of course, when you adopt it, you can certainly try and then decide, how far you want to go. So you can obviously choose smaller tumors, lateral wall, posterior wall, anterior tumors to begin with. And the thing is, if you really have a worry of doing the procedure, completing a surgery, because we use the bipolar resection lobe, you can always convert to conventional TURBT anytime.
Yeah.
So you just keep on learning and then push your limits further when you feel comfortable. So luckily in our trial, I think most surgeons are quite comfortable in doing it. And it's proven to be generalizable because complication rates are similar and there's a benefit recurrence rate. For bladder tumors, obviously it's more difficult. But then it's kind of an adjustment, manipulation. And also using a resection lobe on Collins knife will be easier than using laser, simply because when it's in the bladder when you use laser, most of the time it's end firing. And the laser is kind of going deeper and deeper, whereas when you use resection lobe and Collins knife, it's kind of a 90-degree downwards type of angle. So it might be slightly easier. But again, it's largely an adjustment of your hand manipulation, and gradually you have the experience to complete it. Yeah.
And, there's always a lot of development from the endoscopic companies in technology, but because we expect this is going to get a lot of interest and people should be taking it on, are there things on your wish list that might lead you to go to Karl Storz or Olympus and say, what would be really good is could you make another widget for me that will go alongside the channel, or some sort of balloon that'll help, or some sort of crushing thing within a balloon? Do you have a wish list now that you've sparked all this interest in little bits of kit that might help improve this even, or make it feasible for larger tumors?
Well, my biggest wish list is actually how we can disseminate the surgical technique properly and more widely. And that's why I'm so happy to be here. I think we need to really almost like a virtual academy, a lot of different videos, different experts teaching how they do the surgery, because, different surgeons have their own ways of doing it. And we just have to learn from each other. I use bipolar mostly, but there are people using home laser, tube laser. It's okay. We learn from each other. I think the equipment wise, in terms of incision, external tumor, I think it's fine. I don't think there's any issue.
So there is no barrier.
The main barrier is the concept, the mentality. And also, if we want to extend beyond 3 centimeter, then that's really where you would have a big challenge on taking out the tumor.
Yeah.
So this is how we can take it out nicely without the risk of tumor seeding. Yeah.
But that's a key point, though, Jeremy. Sometimes when you get these bladder tumors that are big, almost filling half the bladder, and you want to do a good quality resection, it can be extremely challenging, even for very experienced resectors. And I've often wished there was a technique where we could do this like we were peeling it off a bladder. I mean, are there robotic techniques maybe where you can get a couple of arms through the urethra and have two arms and kind of slowly just resect and enucleate bigger tumors away? I mean, could that be on the horizon?
In fact, there are already robotic companies developing so-called transurethral robotic surgery. So I myself tried 2 systems already.
Oh, wow. Okay.
One is entering a clinical phase, but still very early. I think it's still needs some refinement in terms of equipment. The other, I think, is really getting there. At least when I first tried, I'm able to do a decent en-bloc resection in a pig bladder tumor model, and they are really going for FDA trial in the coming few months. So I think you're right. We probably would have these equipments shortly. Yeah.
And I don't think you've got any videos going with this paper, but do you have any videos already? You talked about like an academy, and I know you were teaching at the AUA a couple of weeks ago on it as well, but I think we'd love to see videos.
Sure. In YouTube, certainly you can try to search my videos, or I can just send you a video. You can
we'll edit it in now, yeah. By the
Absolutely.
time viewers are listening, or if you're listening to this on Apple,
Sure.
Tune in, because we're going to play a bit of Jeremy's video over the bit where he talked about his technique earlier.
I'd love to. I think the other thing that, if we have time, I would like to talk about is I think we need so much more work beyond this trial, because this trial is a trial to demonstrate recurrence rate difference. There are some other trials which look into this comparison, but they didn't look into recurrence rate as a primary outcome.
Yeah.
But we're already in the process of doing an IPT meta-analysis, hopefully pooling all those randomized trials together and see whether recurrence rates have a difference after pulling all these trial data. And I think at least in certain subgroups, we'll probably detect a difference. That is really the top-notch evidence that we need to kind of push the way forward. But the other thing is very important is, if we're to say en-bloc resection should be regarded as the first-line approach in doing a surgery, then actually a lot of the other treatment around the surgery has to be redefined. Because all previous treatments, single-dose MMC, second surgery, BCG, all defined based on TURBT.
Yep.
Now we say we want to replace your en-bloc, then what do we recommend for the other parts of the management pathways? And therefore, we actually started a global en-bloc resection registry. So we're not interested in comparing conventional TURBT because we already have the level 1 evidence, and we're going to have the IPT meta-analysis. The whole point of running registry is to have large amount of cases. We so far we have 120 centers joining globally. We aim for 4,000 or 5,000 cases.
Wow.
And therefore for each of the questions, for example, en-bloc resection plus 1 dose MMC versus en-bloc alone, then with thousands of cases, to have a propensity score matching, and therefore we choose really the hopefully with this registry we're able to answer the 10-20 questions around it, relatively high quality, although it's not randomized, but at least a matched cohort study in order to provide some guidance regarding all the subsequent perioperative management following en-bloc resection. So this is really exciting and requires a lot of hard work. Yeah.
That's very true, isn't it? I think this is the first step in really completely changing the treatment paradigm when it comes to non-muscle invasive bladder cancer.
So you do a lot of bladder cancer surgery, and you train a lot of our trainees at Peter Mac in bladder cancer surgery, I know. So what do you think?
I'm going to watch Jeremy's video and start doing this.
And send it to
Absolutely.
Leo and the team and say, this is it, this is the... when I'm looking at the pathologies coming through in the MDT, I'll be asking the pathologist, did you enjoy that big en-bloc beautiful tumor that Renew and her team sent you down?
Well, I mean, already for very, mobile tumors, you do have to maneuver the loop, sometimes to the front of the tumor, sometimes to the side, just to get around the tumor. So, I mean, I suspect some of this technique is already things that we're inherently doing just in our traditional TURBT. We just have to adapt it to a
and do
full en-bloc
it
resection.
exactly. Do
exactly.
It full, even if it's a bit fiddly, you're adding a couple of minutes. But look at the recurrence rate. If you're running the department, you're thinking, hang on, that translates into a lot less, redo TURBTs. Plus, the progression to muscle invasive. I saw that 3 patients versus 0 patients in favor of it, but that's probably too small a number to draw any meaningful conclusions. It's really about recurrence of non-muscle invasive disease, isn't it?
And regarding the pathology and surgical surgery, again, small numbers, but we also gained some insights regarding it, because in the en-bloc resection group, we have 19 patients undergoing cyclical surgery, and 8 of them with negative margins, but they had cyclical due to the usual indication. And basically, all 8 of them had no residual disease upon cyclical, as soon as the initial margins were negative. And then in the remaining 11 patients with positive margin in the first surgery, 5 of them had residual disease. So it kind of is small numbers, but it's an indicator. Basically, we may not have to rely on just a mere high-grade T1 disease. It's more important to look into the margins, whether we're completely resected, then decide whether second surgery is really needed. So this is something that we'll hope to look into further in a subsequent registry study as well. Yeah.
And I really do think the en-bloc resection plus or minus mitomycin, what you find there, I think is going to be really very practice changing.
So you think that if you do an en-bloc resection, you've got a lower recurrence rate. You're not having seeding as going around the back, so you don't need the mitomycin. Is that the hypothesis? Okay, is that your next trial? Because look at this fabulous group of investigators have pulled off a randomized trial during COVID.
Oh, that'll be his registry.
We now look to this Hong Kong group to do more surgical trials, to answer more questions. So what are you up to now, Jeremy? Please tell us there's more great work coming from you and your friends in Hong Kong.
Well, from this trial, there are, some more subgroup analysis going on, but I don't want to review now. I'll come back anytime in the future. But you're right. Surgical technique, to me, it's about improving the outcomes, in particular short term to intermediate term. But in the high-risk groups, as we mentioned, surgery alone is not enough. So we have some subgroup analyses on en-bloc resections with BCG, which we're yet to publish it, and then we can talk about it. It was really, really interesting. And secondly would be the large tumors. So in our center, we actually started a single-arm trial. We allow some leeway in the surgical approach because we believe for large tumors, ensuring a complete resection for non-muscle invasive disease and also proper staging of muscle invasive disease is most important. So some cases we would debulk the tumor first and then do an en-bloc resection of a tumor base. Some patients, when the tumor is really too big, we might even have to take the base in multiple pieces, but the point is really to ensure a good resection throughout the whole surgery. And we have completed the study already. We did pre-operative MRI scan, post-MRI scan, and these results are really nice. So we hope to publish it soon, and then maybe come back here to discuss with the results.
Fantastic.
You would be very welcome to come back here. And for those of you watching on YouTube, you can see on his backdrop, he's got a beautiful view across Victoria Harbour. I haven't been in Hong Kong since COVID, and gosh, I used to be up there very regularly to either transit through or go and see you and your friends and learn from you. Have you been there recently?
No, it's been a long time. I've transited through, but
we'd love to host both of you. Come over.
Excellent.
And I encourage listeners on our podcast and viewers to put Hong Kong on your doorstep. It's a great urological community at the Hong Kong Urologic Association. They run really good meetings and really good preceptorships, and we've always enjoyed going up there and learning from you. And here we are today again, Renu, learning from our friends in Hong Kong.
We love it, Jeremy. This is fantastic. Congratulations.
Thank you so much, and thank you for the invitation. Always a pleasure to be here.
Fantastic. So that's all we have time for on this episode of GU.
It takes a great idea and lots of commitment, and you can pull off a paper
love
like
it,
this.
Love it.
Practice changing.
So well done to them. That was really good fun.
Yeah, absolutely.
That's all we have time for on this episode of GUcast. Thank you again for tuning in. We'll be back soon with lots more stuff. Thank you.